Okay, good evening, everyone. Welcome to our webinar on shoulder pain, treatment and surgery. My name's Vicky and I'm your host this evening. I'm joined by our presenters, consultant orthopaedic surgeons, Mr. Nick Bakti and Mr. Daniel Neen. This presentation will be followed by a question and answer session. So if you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is at the bottom of your screen. This can be done with or without giving your name. Please note that this session is being recorded if you do provide your name. If you'd like to book your consultation, we'll provide contact details at the end of this session. And I'll now hand over to Mr. Neen and Mr. Bakti.
Thank you very much. Right, good evening, everybody. Thank you very much for joining us. This evening, we're going to be talking a little bit around the realm of shoulder pain and what we can offer here at Benedin and sort of other types of treatment that we can offer as well. So to introduce myself a little bit further, as said, I'm an orthopaedic consultant surgeon, and I graduated quite a long time ago now, it feels like, 1999 from London, and then went through the usual training. I actually trained in this area in the southeast and have trained with a lot of the older consultant surgeons in the area. I then went on to have some fellowship training, which is a type of training that we do with surgical training where we specialize even further in our subspecialty field. And I went to Exeter and to New Zealand for a while, and then came back and started my consultancy in Dartford and Sidcup, the NHS Trust there in 2015. I was invited to join Benedin the year after that, and things have progressed along the way, and I'm now a clinical director of Queen Mary's Hospital in Sidcup itself. And I'm proud to say that I brought along the shoulder replacements, anatomic and reverse, to Dartford and Gravesham and introduced them back when I first started. And things have progressed again with this. So I'm now performing about 40 replacements a year, and the average is about 17. So myself and my colleague, Mr. Bakti, perform all of the replacements at our NHS Trust and also perform them here at Benedin, but we'll come on to that later on. And now I introduce my colleague, Mr. Bakti.
Evening, everyone. My name is Nick Bakti, and like Mr. Neen, I'm one of the orthopedic consultants here, as well as Darren Valley Hospital. I graduated from Guy's King St Thomas Hospital in 2008. I did my initial surgical training in Oxford and went on to do my surgical specialist training in Kent, in this region. I was actually Mr. Neen's trainee not too long ago. I went on to do my fellowship in Australia for about 9 months, where I specialized in sports orthopedic surgery and shoulder replacement surgery. And I started in Darren Valley Hospital in 2022. Since then, I've been appointed as the trauma lead for the trust, and I'm also a visiting lecturer at the Canterbury Christchurch University. So now that we've done introductions, today what we're going to cover this evening is a little bit about the anatomy of the shoulder, what can go wrong. Well, a lot of things can go wrong in the shoulder, but we'll cover the common ones. We'll discuss what treatments we can offer for those common ailments. And we will finish off with a short question and answer session at the end. So shoulder pain and symptoms are very common. It tends to increase with age. It can be secondary to dislocations, trauma, fractures, but it can also be due to repetitive work or sports. Sometimes it can be secondary to no particular problems, and this can be the case in frozen shoulder, and we'll discuss that later. But it can also be due to degenerative problems due to wear and tear, such as rotator cuff injury and arthritis of the shoulder. And again, we'll discuss this later. About 1 to 2% of patients who present to the GP present with shoulder problems. and about 70% of this is related to what we call subacromial pain. And that is the area in the shoulder that's right above the ball and socket joint. It doesn't seem to be that important on an X-ray, but in that space itself, there is tendons that help move the shoulder, but there's also a little pillow that's fluid filled that can get inflamed. And in this particular condition, it's called bursitis, can cause quite a lot of symptoms. Sometimes in that area, there is a bony spur that arises from the acromion, and it can cause symptoms what is commonly referred to as impingement, and that can cause quite a lot of problems with overhead activities. So if your job requires you to do lots of overhead movements, this can be quite debilitating. The shoulder joint itself, as a whole, is quite unstable. The reason for this is that the shoulder joint itself has to be quite mobile for us to get our hand to where we want it to be. Unlike the hip joint, where it's a deep socket, the shoulder joint itself is not. And the stability of the shoulder is very much given by the muscles and tendons around it. So this picture, this image here shows the ball and socket joint for the shoulder, and the ligaments around it and the tendons around it. The tendon that crosses the shoulder joint itself is the long head of biceps, and in some conditions can be irritated, can be inflamed, and can cause quite a lot of pain. The tendon itself crosses the joint in the capsule, and in certain conditions such as frozen shoulder or adhesive capsulitis, can get very inflamed, and this results in symptoms such as stiffness and ongoing pain. This slide here shows how complex the tendons and muscles around the shoulder is, and it will bring us on to how important physiotherapy is in managing shoulder pathology or pain. The key bit in this slide is to show the components or the muscles and tendons that make up the rotator cuff. There are four main muscles: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. And apart from shoulder stability, these muscles and tendons help with movement of the shoulder. The tendon that's most commonly injured or damaged in rotator cuff problems is the supraspinatus tendon. Around these tendons would be the deltoid and the pec major muscle. And again, they are very important in physiotherapy in helping treat shoulder problems. This is again another image to just show how closely related the shoulder joint is with the muscles around it. And I'm going to hand you back to Mr. Neen to talk about treatments for shoulder pathology.
Thank you very much. Right, yes. So treatment for pain and injuries obviously would very much depend on what sort of diagnosis we come to. All sorts of things can cause the pain, as mentioned by Mr. Bakti. That even includes things coming from your neck. So the neck can cause pinching of a nerve that supplies the area. So part of our job is really to give you the diagnosis as to why you're getting the pain in the first place. Once we've reached that diagnosis, we can then suggest various treatment modalities. Physiotherapy is by and large the first stage of all treatments, and a lot of the people we see have already had that physiotherapy commenced by their GP, for example, or have sought physiotherapy themselves. Osteopathy can also play a role in this, and increasingly is doing so actually. If we have a diagnosis of inflammation within the shoulder, then one of the very powerful tools that we can use is a steroid injection. And that's a very strong anti-inflammatory. It's not the type of steroids that people use to build up muscles. That's a different type of steroid. They're very much more along the lines of the anti-inflammatories that you can buy in a chemist, such as ibuprofen or diclofenac on prescription, but those are non-steroidal anti-inflammatories. We use a steroidal anti-inflammatory. So again, this can be injected right into the area where you're getting a lot of the inflammation. It can help matters. Even if it doesn't last long, it can be diagnostic in its use as well. If all these modalities have been tried, so time, rest, changing what you do, physiotherapy, even a steroid injection, and we're sure of the diagnosis, but things still haven't cleared up, then surgery does have a role to play. The vast majority of things do seem to clear up on their own, though, with the sort of conservative or non-operative management that we use. If you come to an operation, there are various things that we can do, and it does again depend on really what the underlying diagnosis is. A lot of the soft tissue procedures that we do these days are keyhole surgery, otherwise known as arthroscopic, and it involves very small holes being made around the shoulder girdle for us to introduce these tools that we use to cut or remove or fix and repair. As you can see on the slide, there are various things that we can do with tendons from repairing them. We can stabilize the shoulder itself. We can release the shoulder in things like frozen shoulder, or we can even replace the joint itself, but that is more of an open procedure. Physiotherapy itself is, as discussed, one of our mainstay of treatments. We've already talked about how unstable the joint is potentially, and if you have a degree of instability, then balancing that joint is a very important proponent, and the physiotherapists do their best to sort of balance the front and back muscles. Some of this is also involved in posture, and increasingly these days we're bending over desks for hours at a time with our shoulders hunched forwards, and this we know encroaches on the tendons underneath the acromion bone at the top, the ledge of bone that you can feel. Exercises will help maintain tone of the muscles, help keep the joints supple, and hopefully help with the inflammation. But again, it's not a quick fix. It does take quite a few sessions of physiotherapy and maintaining that balance to then have the prolonged effects and benefits. One of the key things that physiotherapists and indeed Mr. Bakti and I see is a diagnosis called impingement. If we go back, about 70% of pain that comes from a shoulder will involve this diagnosis. We've talked about the acromion, which is the little ledge of bone across the top, and underneath that there's a cushion called the bursa, and underneath that is the tendon supraspinatus at the top before the joint itself. And what happens, it either depends on the movement of the joint itself or the way that you use it, or indeed it can just be due to wear and tear itself. But the tendon, the supraspinatus, which is the most common tendon involved in this, encroaches on the bone or starts to peel off its attachment and wear out. This can cause inflammation not only in the tendon itself, a tendinitis, but also the bursa above it. So that's a bursitis. And both of those can cause a lot of pain, particularly with certain movements. One of the anatomical things that can happen to cause this is that bone above it can be curved. So some people have a flat ledge of bone, some people have a curved ledge of bone. And depending on the amount of curvature will depend on how much room that tendon has to move. We can see the spurs of bone quite clearly, usually on an X-ray. And it appears on this front-facing X-ray, the ball and socket side by side, and then this acromial ledge above with a spur of bone. And as you can see, it's sitting right above the head, just where that tendon would normally fit. You won't see a tendon or you won't see cartilage on an X-ray because neither of those have got calcium in them, so they don't show up on the image. However, there is a way of looking at the soft tissues, the calcium and the cartilage, with various other forms that we use of imaging. This is called an MRI scan. And so this image, we can see exactly the same as the X-ray, but the gap in between the bone above and below, you can see that there is an image of a tendon, and that green arrow points to a little area above it, which is inflammation, and the red arrow points to a gap in that tendon where it normally attaches down to the ledge of bone to help move it. It's detached, and you see this bright white area where more fluid is present. So this is a torn tendon. A little animation here of what impingement is. So as you take that arm out to the side, that ledge of bone where the tendon attaches rubs up underneath the acromion, causing more pain. So what do we do? As I've already discussed, physiotherapy may be an injection to help diagnose it and to relieve it, and sometimes that's all that's necessary. But if it fails to alleviate, unfortunately, it does sometimes come to surgery. Or fortunately, as you may see it, there is something we can do. So keyhole surgery, as this little animation demonstrates, is designed to burr away an undersurface of that acromion. And in doing so, we create more room for that tendon to move. The operation itself is a day surgery, so you're in just for the day, although it still does involve a general anesthetic, meaning you're asleep. You're in a sling, usually just for a couple of days, but can be longer just for comfort reasons. And then we're expecting most people to return to work within 3 to 6 weeks. Usually 2 little holes, about 4 millimeters each, are used to do the actual operation, and they heal within a couple of weeks. And I'll hand you over to Mr. Bakti to talk about the next common diagnosis we see.
So the next common diagnosis that I want to talk about is frozen shoulder, but it is also often referred to adhesive capsulitis. So this is one of those insidious onset problems to your shoulder that starts off often spontaneous, sometimes can be due to trivial trauma where you just knocked your shoulder at the side of the door, and it progressively gets more painful and, more importantly, stiff. The pain and the stiffness becomes quite unbearable sometimes. It can be a problem at night, waking you up at night. And the biggest issue is in most of the patients that I see, this is what we call idiopathic, where we don't actually know the cause of frozen shoulder. As I mentioned before, it can be quite debilitating, especially when you are unable to get a good night's sleep due to the pain. The stiffness often sets in later, after a few months, and then the pain settles, but the stiffness tends to stay there if the inappropriate treatment is not started. The underlying problem in frozen shoulder is that the lining of the joint, or the capsule itself, gets very inflamed, and with time it scars down, and because of the scarring, it's no longer supple and it affects your movement. It is when it's inflamed that's when the shoulder is painful. The mainstay of treatment of frozen shoulder is physiotherapy. The problem that most of my patients complain of is that they're unable to do the physiotherapy and stretches because of the pain. So secondary to the physiotherapy, our treatments often involve pain management. And this can either be a steroid injection into the shoulder. Sometimes this can be done in clinic, but often this is done under X-ray guidance or ultrasound guidance. If movement is an issue on top of the pain, or stiffness is an issue on top of the pain, then there is a secondary or a different kind of injection that can be given, and this is termed hydrodistension, when lots of fluid, saline, is put into the shoulder to expand the capsule that has previously been scarred to help not only with the pain, but also with the movement. Often this takes months on top of the injection and the hydrodestension and physiotherapy, but after a period of trial of conservative treatment with these treatments, if your movement is no better, then surgery can be considered. Most patients with frozen shoulder resolve without surgery. If surgery is needed, then again, it's very similar to an impingement operation, where it's done again as a keyhole operation, again as a day surgery, but under general anesthetic, where whilst asleep, the shoulder is put through a range of motion to help with the stiffness, and then a camera is put into the shoulder where the scarred capsule is then released to help with the movement. Again, following the operation, you'll be in a sling for a couple of days. And very importantly, after the operation, is to not stay in a sling for too long, as then the stiffness might reconstitute. Physiotherapy is key to help you get your range of motion and strength again. And often patients do get back to work and driving within 3 to 6 weeks, depending on the nature of your job. The next big diagnosis that we often see is rotator cuff injury. The two main groups of rotator cuff injury, one is traumatic, when you fall or you have an injury to have torn your rotator cuff, and the other is due to wear and tear, possibly due to a spur at the top of your acromion. The symptoms that you get with rotator cuff injury is the inability or pain in doing overhead movements. And often this is associated with weakness in these movements. As mentioned earlier, the tendon that's most likely to be involved is the supraspinatus tendon, but any of these four can be injured or torn. The most common way to diagnose this is an ultrasound scan, and this is widely available in your GP practice, in musculoskeletal clinics, and therefore it's often offered to patients. It's a good way to assess for cuff problems because it's readily available, and sometimes patients are unable to do further imaging such as an MRI scan, but in my opinion, an MRI scan, it's much more revealing, as it tells us not only about the tear itself, but it also tells us how far the tear has progressed, and it gives us an idea whether it's repairable based on how much it's retracted and whether the muscle itself is still viable. So in most of my patients, if we are considering rotator cuff surgery, then I would almost certainly, unless there's a reason not to, carry out an MRI scan to give me a better idea of your shoulder. Once that has been confirmed, then we discuss options of treatment. Not all cuff tears have to be treated with an operation. This is particularly true for partial thickness cuff tears. Quite a lot of patients or members of the public have partial thickness cuff tears. Most of us don't even know we have a partial thickness cuff tear. And often this is an incidental finding on either an ultrasound scan or an MRI scan. This partial thickness cuff tears can be treated without an operation, often with physiotherapy and time, but sometimes require an injection to help calm any inflammation around that. The cuff tears that have to have or should be considered for an operation are full thickness cuff tears that hasn't responded well to physiotherapy and injections, or traumatic cuff tears. That would be cuff tears that has happened following an injury, such as a fall or a dislocation. So again, most calf repairs are done as a day case, and most of them can be done keyhole. Very few of calf tears are not possible to be done using keyhole treatment or methods, and sometimes will require a slightly bigger incision or a cut in order for us to access it. But in my experience, 95% to 99% of calf tears can be dealt with using keyhole operation. Similar to impingement operations, this is done as a general anesthetic, as a day case. And what happens during the operation is that we identify the tear. We then freshen up the tear so that it has the potential to heal onto the bone or where it's supposed to be attached. We will then place what we call anchors into the bone. These are plastic anchors. So traditionally, they were metallic anchors, but now we've got improvement in materials that will allow us to do this using plastic anchors, which are less damaging to the bone and allow us to carry out further imaging in the future if needed. So with these anchors, there are some sutures that we will then use to grab the tendon that's torn, and we will cinch it down to the bone. The difference between rotator cuff surgery compared to frozen shoulder surgery and impingement surgery is that following the repair, the immobilization in a sling is slightly longer, anything between 4 and 6 weeks. And this is to allow the repaired tendon to settle into the bone. And if we don't do this, then there's a higher increase or higher chance of failure of the repair. Following the immobilization in a sling, then physiotherapy is key. First to get rid of the stiffness in the shoulder, so your range of motion. And then the second part of the recovery and the physiotherapy is to get back your strength into the muscles. Often, patients are back driving at about 6 weeks. Patients with more manual work, then they tend to go back slightly later. But if you are more office-based, then often they're back at work at about 6 weeks or so. I'll pass you back on to Mr. Neen to discuss shoulder arthritis.
Okay, for our final topic then, shoulder arthritis. Just like any joint in our bodies, we can develop arthritis in the shoulder. And in essence, arthritis is the wearing away or the eating away of the cartilage lining the joint. The cartilage is what gives it its slippery surface. Cartilage has no feeling. You can do what you like to it. It won't cause any problems. But once the cartilage has gone, the underlying bone does have feeling. And that's where the inflammation and the pain starts coming into play. In this particular X-ray, we can see, I don't know if you can see the difference between the images we've shown beforehand, but this ball is now ridden up underneath that acromion. And in fact, the acromion looks like it's wearing away quite considerably, and it's come out of its socket as that arthritis progresses, and the bone is rubbing on the bone on 2 occasions there. There are different forms of the arthritis. This is one extreme example of this, but it can be due to either degenerative changes that we normally get or an inflammatory process, or it can be a traumatic process after an injury to the joint itself. Very commonly, people will have good and bad days to start off with the good days outweighing the bad days, but then more and more it can be that the bad days start impeding things that they can do during the day, activities of daily living, such as dressing yourself or cleaning yourself. And the pain can become quite intrusive. So keeping you awake at night is one of the key things that we look for. Another thing that people talk about when moving their arthritic joints, the clicking noises or the creaking noises that they can sometimes get as the bone grinds on the surface. On this occasion, we can see that there's a large lump that has grown of bone at the bottom aspect of the ball with a small loose fragment at the top. And this is another form of arthritis that we can see on an X-ray. It's called an osteophyte, and they do become more common with the damage to the joint surface as the joint tries to spread the weight of the load out. And on this one is another typical finding of arthritis. You can see there is absolutely no gap really between the two bones. You can just about make out the ball and the socket where they used to be, but there's no gap between the bones, and that is bone on bone arthritis. And again, that potentially can be very painful. Treatment-wise, really would depend on how severe things are getting. If it's not affecting you too badly, then physiotherapy just to maintain the muscles and the tone of the muscle and the range of movement as best you can would be the mainstay of treatment. This is a progressive disease, unfortunately. It does gradually get worse, certainly on the X-rays, but the symptoms don't necessarily match X-rays. It gives us the underlying diagnosis, but pain is the main thing that we're interested in treating, and we know that we can help. If it becomes moderate, then there are certain things that we can do with arthroscopy and keyhole surgery to debride or clean up the joint itself. But again, the progression of the disease is not going to be halted altogether by doing so. We're basically buying some time. When it gets to severe symptoms, pain, wake you up at night, or things really getting desperate during the day, then we discuss alternatives. And one such alternative would be a shoulder replacement. Just again, much as most people have heard about hip replacements and knee replacements, which are very common in this country, shoulder replacements are becoming more common. And it's surprising that more and more people are knowing about it, interestingly. When they come in, they've never heard of a shoulder replacement before, but it is possible. As discussed, really, we would only be talking about it as a needs-must surgery because it is a major undertaking. However, it's very effective at dealing with pain. It certainly helps with mobility. It doesn't make it a normal joint by any means, but it can help with the mobility from a very stiff joint. However, the stiffer the joint is beforehand, the stiffer it is afterwards as well. So we can't guarantee that range of movement, unfortunately, but the pain is something that we certainly do help with. An interesting modality that we use is something called a reverse shoulder. And a reason I bring this up is, again, a lot of people, not only have they never heard of a shoulder replacement, but a lot of people had a lot of bad press about shoulder replacements because of what we used to do in the not too distant past. We used to just replace one half of the shoulder, thinking that this was the best thing. We were replacing the painful joint surface. But unfortunately, we still had the other side being painful. And also, unfortunately, because of a lack of tendon, that metal surface would then ride out of its joint and start causing other issues elsewhere. And everything would be more painful and stiff despite the operation. So back in I think it started in the 80s, but certainly in the 90s, this gentleman, Grammont, came up with the idea of reversing the geometry of the shoulder. So the ball and socket, as we can see in the picture, is normally situated on the left-hand side there. But if you turn that socket into a ball and the ball aspect into a socket, you can actually make it so that the humerus, or the arm bone itself, cannot ride up underneath the acromion. It also stretches out that side muscle there, the deltoid, which means it's happier to do the movement, the lifting of the arm, without the tendons that have disappeared on their own. The system we use is called Equinox. It's got a long track record. It's particularly used in America, but has been over here for a number of years now. And we seem to have very good results from it. It's good stability, and it has its track record is improving and growing in evidence. Should you come to shoulder surgery, Usually, as we talked about, it's a day admission. So you come in either on the morning or in the late afternoon, depending when your appointment is. You'll be greeted by the nursing staff up on the ward. The anaesthetist will come around and just check your general health and make sure that you're not currently ill. You'll then be seen by the surgeon, maybe just to do some final checks and paperwork. And usually we put an arrow on the arm that we're going to be operating on. You then have a general anaesthetic because you're asleep, but they also usually offer you a nerve block. And what that is, an injection in your neck or the base of your neck near the nerves that go down your arm, so that when you wake up, you have no pain. Unfortunately, it's a bit of a weird feeling, I'm told, in that you can't move your arm, but it's the pain aspect, once again, that we're trying to help with. And it doesn't last forever. It sort of usually works its way out within the first 24 hours. During that time, however, it's very important that people take painkillers to keep up with the pain so that they don't wake up with it and then try and chase the pain, which is a very difficult situation. If you're having a shoulder replacement or a joint replacement, you tend to stay in one night. And I think that's pretty much the longest time people stay in with shoulder surgery and arm surgery in general. You have your arm in a sling until it wakes up, certainly. And then depending on what operation you've had will depend on how long you need to wear that sling for. Physiotherapy is then commenced relatively soon after the operation and usually goes on for 2 or 3 months just to get you through the whole rehabilitation exercise process. And so then you can carry on with your own exercises on your own. Driving wise, most people ask about when they can drive. And again, it depends what you have done. If it's something bigger like a rotator cuff repair or a shoulder replacement, then you're looking at about 6 weeks to attempt. It doesn't mean that you have to drive. It's very much more a confidence building exercise. And so when you feel able to, but it's usually from the 6-week mark that you start trying. Normal activities, well, usually within the first 3 weeks, we're hoping that the movements will have improved to about 50% of before the operation level of activity. But passive movements, we want to have improved by about week 6. Now, passive means that somebody is moving the arm for you or you're doing it with your other arm. Active movements, we hope to be at least to the preoperative level by about 3 months. Driving, as I said, is about 6 weeks, or from 6 weeks. People ask about golf, and that's about 12 weeks, and swimming. And so it depends on the stroke that you use. Freestyle, again, is a bit more active, and so we're looking from about 12 weeks. Lifting weights after a shoulder replacement can begin fairly quickly with the physiotherapist's guidance, but we're talking about very light resistance. And any heavy items should be avoided for about 6 months while that soft tissue reforms and stabilizes the joint itself. Joint replacements are increasing in numbers, especially in this country. We're very fortunate to have a national joint registry in this country, which I'll come on to in a second. But it keeps track of how many joints are actually going in. And as we can see, shoulders were at the 8,000s mark at this point in time. There was a little dip in 2020 with COVID, but that was the same for everything, where everything seemed to about halve. But obviously we're nowhere near the order of hips and knees, which are over 100,000 operations per year. Ankles and elbows are lagging behind. But again, I think there's just not the demand for that sort of replacement just at the present time, and technology is improving for them. The National Joint Registry in this country, it's the biggest in the world, actually. For shoulders in particular, we started capturing the information about all the joint replacements going in since 2012. As you can see, when we first started out, it was about 35% of them were hemiarthroplasties. What that means is that we were replacing the ball component only out of the ball and socket joint. The socket was left alone. About a quarter of them were then the ball and socket total replacements, and about a quarter again the reverse polarity ones. But things have changed, and these hemiarthroplasties that are going out of favor, we tend to potentially do them in very young patients where we want to try and preserve the socket if we can. But about 20% are now total shoulders, so we replace both the ball and the socket in the normal alignment, anatomic replacement as we call it, or 63% are now the reverse polarities. And certainly in my practice, that's what I've seen. The vast majority are these reverses because they do so well. There's another 10% unconfirmed reverses, so that figure may even be closer to 3/4 of all the shoulder replacements. Technology is coming on, and both Mr. Bakti and I are privileged to use 3D modeling. This helps us plan the operation before we actually go in. We take a CT scan. This allows us to build a 3D model of the shoulder blade, including the socket. And in that way, we are able to size and place the implant precisely. And we can plan ahead of schedule. And seldom is it that we were having to go against what the plan was originally. We also use navigated shoulder replacements now. So navigation is another level altogether. So once we've planned it, we're then able to use the technology available to us to actually guide where we place the drill holes, the plate itself, and we can see in real time where the drill is going. So this helps us avoid any accidental drilling into places we don't want to. It helps us visualize where these screws are going to end up, and it helps reassure us as much as anything that we're putting this plate exactly where we wanted to in the first place.
Lovely, thank you both for a very interesting presentation. So we've now got some time for some questions. So we can start off with Ted, and Ted says, I'm age 90 years old and I have right shoulder full thickness rotator cuff tear with proximal migration of the humerus. I'm not in pain but have limited use of my arm. I can't raise it above horizontal. My wife is disabled and dependent on me. Recommendation, please.
Okay. Right. Good evening, Ted. Thank you very much for your question. So you have what sounds like very much the X-ray that I demonstrated earlier with that proximal migration, that high riding of the humeral head up underneath the acromion. That tear is a common finding that we see in people, usually from the age of 70 onwards. So you're not alone by any means. But because of that proximal migration, the humeral head will then develop a degree of arthritis potentially, and it will limit the movements that you have. Now, pain not being a factor is an extremely good thing. And that is the thing that we usually are going for with surgery and can guarantee that we sort of try and help. The movements are not something that we can guarantee. So as with all these things, it's always good to sort of talk you through your options, but physiotherapy may be a benefit to you. Alternatively, some injections and some gentle stretching exercises may be of benefit as well. Surgery-wise, if pain isn't an issue, then I would probably not go down that route. I would probably say avoid it, because the problem with surgery is that there are very small risks involved with it. And if you have no pain at all, and we try and do an operation but potentially makes it painful for you, then you can actually end up in a worse situation. So my recommendation probably on that would be to avoid the operation if possible, but also there are always nuances.
Thank you for that. Next question. My shoulder hurts mainly at night or when leaning on it for a long time. It disrupts my sleep, but I can get on fine with day-to-day tasks with a little stiffness. Would you suggest waiting until it gets worse or get it looked at before it does?
So thank you for the question. I think it's always an issue when it affects your sleep, because it just sets the tone for the day, and it becomes, sometimes can be quite unmanageable. So the issue here is that during the day, it's not a problem and you have little stiffness. And sometimes you wonder if it's coming from your neck. And about 20% of patients that I see in clinic that has been referred for shoulder problems actually have a neck issue. So I think it's quite difficult to say whether to leave it and wait until it gets worse. But my mantra for this is to know what's going on so that we can nip it in the bud. So if you feel that the problem is bad enough, I would recommend that you see someone. It could be someone you have easy access to, like a physiotherapist or your GP, to see where the problem might be coming from, either your shoulder or your neck. Get some simple imaging, such as an ultrasound scan, to see if there's any inflammation of the tendon. And it could be something as simple as posture, physiotherapy, or even an injection, if there's nothing major like a tear that needs dealing with. So I would say get it looked at sooner rather than later, and nip it in the bud.
It's quite interesting. We see a lot of people with night pain, and I think a lot of this is to do with gravity. So when you're up during the day, one, you have distractions to take your mind off it, but also your arm, the weight of the arm is hanging down. Whereas when you lie down at night time, the arm is then shoved up, you have no weight pulling it down, and that can actually squash the area that is inflamed already, and that aggravates the pain for you. And then with nighttime, you have no distractions either.
Okay, lovely, thank you both. Next question, my shoulder pain flares up and then settles down again. Is that pattern most likely due to osteoarthritis? I have it everywhere else, so I don't see why my shoulder should be exempt.
Yeah. Flaring up and settling down absolutely can be a very arthritic type picture. It can be to do with what you do during the day. If you overuse the joint or use it for doing a lot of heavy lifting, for example, the joint is damaged in essence with arthritis, and so that will stir up trouble. It will stir up the inflammation. But then a lot of the other common conditions that we see in the shoulder also have this sort of clinical picture where the more you use them, the more it stirs up the inflammation and the more painful it gets, until the point that you can't use it. So you rest it and everything starts to settle down again. So unfortunately, there are lots of pieces to the jigsaw that we would have to put together. And although osteoarthritis is certainly one of the possibilities, I wouldn't say, I could definitely say it's that.
Okay, thank you. Hope that was useful. Next question is for Milton, and they ask, 20 years ago, I suffered multiple fractures to the proximal humerus in a rock climbing accident. Now have severe arthritis in the glenohumeral joint. Keen long distance road cyclist. Despite restricted arm mobility, I can ride my bike and currently manage the pain without painkillers. If I have a shoulder replacement and fall off my bike on the artificial shoulder, would the consequences for me be greater than if I don't have the replacement?
Right. So thank you for your question. Well done on managing at the moment, and injuries in the past, like fractures, can set off arthritis. I feel that if you're managing and it's not impinging on your day-to-day activities and the hobbies that you have, I think it's best to delay a shoulder replacement as long as you can. As you correctly mentioned, if you did fall off your bike and you have a shoulder replacement in place, the worst case scenario is that you fracture around the stem of the shoulder replacement, and very rarely we can treat this without an operation, but often it means that we will have to go in there and fix it, sometimes with the plates and some screws, and sometimes by having to revise the whole construct itself. So it can have quite dire consequences if you fell off your bike with an artificial shoulder in place. So I think whilst you're managing without painkillers and you're still able to do what you want to and can do, delay the need for any shoulder replacement. What do you think, Kristen?
I absolutely agree. Yeah, quality. The point with the artificial shoulders or joint replacements, it won't give you a normal feeling shoulder necessarily, but it will help with the quality of your life. So if you are struggling with the pain particularly, then I think that that's certainly something to explore. But it sounds like you're able to do everything you want to do, and you're coping with the pain at the moment. So absolutely, I would continue as you are until you absolutely have to. You'll know when you want the operation.
Lovely, thank you both. Hope that was helpful to you, Milton. Got time for another couple of questions. This one's from Anthony. I've just had a spur removed that was causing an impingement. Shoulder is more painful at night. How long does it take to recover?
Yeah. In general, we say that most people, if it's just an impingement surgery, i.e. shaving away the bone and clearing away the bursa, most people are getting better within the first 3 months. Shoulders are peculiar things though, and they can take longer than expected, certainly even if it's soft tissue type stuff that we're doing. And so as with physiotherapy, we advise people that it can take anywhere between 6 to 9 months to improve. However, what is problematic for you is the pain at night particularly. And one of the key things that we need to rule out or potentially look for is the development of frozen shoulder. So we talked about frozen shoulder a bit before, and it can come on for no reason at all. But unfortunately, one of the reasons it can come on is after a trauma, and surgery is a type of trauma. So in an unfortunate very few people, they do develop the secondary complication of a frozen shoulder. And so this is something that will be monitored in your recovery by your surgeon. Other than that, it can take months rather than weeks to get over this type of operation, unfortunately.
Okay, lovely, thank you. Next from Peter, what's the average lifespan of a shoulder replacement before it may need revision?
So great question, Peter. And I think this is why we have our National Joint Registry. And I think based on a few factors, such as why you needed the joint replacement in the first place, and sometimes which implant you use and what type of a shoulder replacement you have, so either an anatomic or a reverse, it can last up to about 15 plus years. Sometimes if you have anatomic shoulder and if your tendons then get injured, then the need for revision may be sooner, or if you have other complications such as fractures or dislocations. But in general, in a straightforward primary shoulder replacement, one can expect it to last between 12 to 15 years.
I think the latest, I think that's correct. I think the latest data was that about 6% of shoulder replacements needed revision at about 10 years. So it's a relatively low number.
Okay, lovely, thank you. Next question is from Andrew, and he asks, can keyhole surgery help my PVNS if diagnosed?
That's a very specific question, that.
It's rare to get PVNS in the shoulder, but it can happen. But like the knee, where one of the treatments for PVNS is to remove the inflamed synovium, then yes, potentially keyhole operation to remove all the inflamed capsule around the shoulder can help. But the problem with PVNS is that there's a higher risk of recurrence. So it's the other treatments on top of the keyhole operation, such as medicines and possibly steroid injections, is the one that's going to help long-term treatment of PVNS.
Okay, lovely, thank you. Next question is from Robert, and Robert asks, does bursitis clear by itself? I have a torn tendon and have been doing physio for 6 months, still uncomfortable though.
So it's the underlying cause of the bursitis that's the issue, probably. We've discussed torn tendons in the talk, and there are partial tears which are not too significant, but there can be torn tendons that are fully torn. And the problem with a fully torn tendon is that there is no way that that tendon can get back down to the bone without help. Now, the bursitis is probably a secondary phenomenon. It could be due to the reason that you had the torn tendon in the first place, with that impingement aspect of things that we were talking about. So I think you're going through the whole non-operative phase at the present time. 6 months is probably a very good time to say, let's reevaluate the situation at this point in time. 6 months with pain is quite something. So yes, I think it's probably time to reevaluate at this point and just come and talk to somebody about what to do if it's really still hurting you and causing symptoms.
Okay, lovely, thank you. So I think we'll have to make this the last question from Ian. So Ian had surgery after a fall, directly hitting his shoulder. Injection and physio didn't help. He's had keyhole, subacromial decompression and trimming of the collarbone. Also tendons that were rubbing were trimmed. Over a year and a half ago, he still has pain. Recently had an X-ray showing significant separation of the clavicle and acromion, also showing a false joint. What are your suggestions to help this problem? He's seeing a surgeon next month.
Quite a complicated question there, Ian, but not having any benefit of your X-ray, it sounds like the joint where the collarbone meets the shoulder blade, known as the acromioclavicular joint, seems to have separated. And this is it's a small joint, but it's quite an important joint because it takes most of the load from the shoulder. And when it doesn't work properly, it can cause quite an issue. It sounds like that joint is now incompetent, and we call it dissociated. And I think what you need would be to come and to see someone about it, get some formal imaging on it. And if it is what I think it is, then you might benefit from reconstructing that joint. But again, I don't have the benefit of your X-rays. So I think that you've given it enough time after your operation. And if that's the case, then you may need something else doing to it.
It's quite interesting that the gap has increased fivefold. So when we do this acromioclavicular joint, which is the joint between your collarbone and your shoulder blade, we actually just take off the end of the collarbone itself. As you've said, they're 5 millimeters. That's all that we want to take off to increase that gap. You've got a little space to take a bit more, but we want to preserve the ligaments, so we don't want to take too much. With it having gone 26 millimeters now, that's quite an interesting number. But again, we're looking at all these images, whereas usually what we do is we use an image to confirm a clinical suspicion or diagnosis. And so I think what we're missing from that history really is, where is the pain, and clinically, where is the pain? And then we could maybe do some injections to diagnose where that pain is. So if we were thinking it was the gap that you had, the acromioclavicular joint, we could numb that to see if that helps with the pain, because it may be that we're focusing on that area and in fact it's elsewhere that's causing it. But that gap is quite a large one, so I'll be interested to know what's caused it.
Okay, lovely. Thank you both very much. Sorry if we didn't answer all your questions. If you've provided your name, we will answer via email. So as a thank you for joining this session, we're offering 50% off the value of your consultation for a limited period. Call back from your dedicated private patient advisor, an email with the recording, treatment information and loyalty reward points, and updates on news and future events as well. We'd be grateful if you could complete the survey at the end of this session to help us shape our future webinars. If you'd like to discuss or book your consultation, our private patient team can take your call until 8:30 this evening, or between 8 AM and 6 PM, Monday to Friday, using the number on the screen. We've got some more events coming up next month on varicose vein treatments and hip and knee osteoarthritis, and you can sign up to these via our website. So on behalf of Mr. Bakti and Mr. Neen and the expert teams here at Benenden Hospital, I'd like to say thank you very much for joining us this evening, and we hope to hear from you very soon. Thank you and goodbye.
Thank you.